Okay, well, great, thank you. And I'm very thankful also for the introduction that James had given around us all feeling like we're starting and trying to figure this out, because I think that's where you'll find us in this discussion today. But it really is my pleasure to be here today with Dr. Lishka and Anna Hussey. And we're going to present to you a recent paper we published on confronting complexity and supporting transformation through health systems mapping. And we really also want to acknowledge at this point too that this is just three of us in a much bigger team. And we also even had James helping us as we went through. So this is certainly a collaborative piece in this very complex world. So next slide. I'm going to spend a little bit of time today starting off just talking about the challenge and giving you a lay of the land, so to speak, an overview of our health system right now. And you're going to hear then from Dr. Lishka about how our health system is in fact complex, if you needed any convincing, but he's going to go over that in a little more detail. And then Anna's going to take over and talk about, what we did in creating our visual representation and how we use complexity theory. And if time allows us, we'll certainly spend some time talking about our next steps and where we're hoping to go with complexity theory and this work. Next slide. Okay, so Ontario is undergoing one of the largest, if not the largest, health system transformation that it's ever gone through. It's a really exciting time to be a health systems researcher like myself. And so what we're faced with is this large system level transformation at a provincial level. So Ontario is introducing a new model of regional healthcare called Ontario Health Teams. And these Ontario Health Teams are regional models of care. Currently in the province, there's about 50. There's talk of potentially about 100 that are going to be formed, maybe more, maybe less. The point is, it's happening in real time, it's complex, and we're not even really sure what they're going to look like. And so we are building the plane as it's flying. I think I've heard that saying happening before. The goal of these OHTs is to provide and to build a modern, sustainable, integrated health system with impacts that are defined by the quadruple aim. So if you're not familiar with the quadruple aim, the diagram on the right there shows you, or maybe it's your left, it's the right, shows you the four aims. So the original triple aim introduced to us by the Institute of Health Information down the States. This is the quadruple aim, where we look at the importance of improving clinician experience, improving outcomes, better outcomes, improving patient experience, all at lower cost. So some folks have also added a fifth aim called the equity aim and the quadruple aim, but we're focusing on this one. So this story today, we're going to tell you, is the story of one OHT's journey along the path to this transformation. Next slide. So this map, hopefully you recognize the orange spot. That's where we're situated. If you're joining us here from Western Ontario, that's the Western or the Middlesex London OHT. So there's been a name change in the past few months. So you might have heard of the Middlesex London OHT referred to as the Western OHT, but it's one and the same, and the name change is now official. So healthcare providers are collaborating to develop and implement the Middlesex London OHT. And so this region of the Middlesex London area covers about 500,000 people at maturity. Middlesex London's focus for the first year was on the system integration to support patients with chronic obstructive pulmonary disease, COPD, and heart failure. So each OHT across the province was tasked with picking their year one priority population. And so that process in and of itself was quite complex. So the Middlesex London, through a process of consultation and collaboration, set up a coordinating council and set out to figure out what would this year one priority population look like. And so the coordinating council, in consultation with the public, decided that it would be COPD and heart failure. Then the coordinating council further subdivided into a working group, several working groups, but the one in particular we're going to talk to you about today was a working group to better understand the current state of care, but specifically care for COPD and CHF and heart failure within our region. So we have a coordinating council that decided we're going to focus on COPD. We have a smaller working group that's going to focus on what is the current state, and then a smaller subgroup, of which Dr. Lishka was a part of, and Anna, who are going to coordinate this first phase. So that brings us to our challenge. So this is challenging enough, but our main challenge now is understanding and developing an understanding of the current state of healthcare as it relates to these two target diseases, using a co-creation approach. So again, if you're familiar with the Ontario Health Team development, you'll know, but I'll remind those maybe who are not as familiar, that co-creation was embedded in all levels of OHT development. Co-creation, not just co-creation from the standpoint of administrators, but administrators, clinicians, providers, all the way down to, and most importantly, the patient level. So we have 3 objectives from this major challenge that were set out. We want to identify sectors and their contributions across the biopsychosocial continuum. We want to foster a common understanding of the whole healthcare system within our region and create a shared transformation agenda. And then we want to use complexity theory as a guide to our approach to both doing this work and interpreting our findings. So this is all set on the stage of a very complex transformation in a very complex system. So next, we're going to hear from Dr. Lishka and understanding just how complex this healthcare system is.
Thanks, Shannon. Actually, it's Anna on this, but no worries.
We did practice. That was my
fault. So good morning, everybody, and thanks, Shannon. So how does the healthcare system fit into the context of a complex system? So first of all, I think we mentioned our 2 target diseases. So chronic obstructive pulmonary disease and heart failure have been identified by the Middlesex London OHT as a population in need of system-level care coordination and supported primary care management. Now, these are 2 high-burden diseases. This patient population tend to be older, management is complex, and patients with these diseases are predominantly managed in primary care. Now, the graph gives you an idea of the burden in Canada, but to give you an idea, in Ontario, we have a combined for these 2 diseases, 56,000 hospitalizations per year, amounting to 500,000 hospital days, which costs the system over $500 million per year for Ontario. So not only is there a high health system burden, but there's also significant burden to the patient with a reduction in quality of life. So understanding healthcare as a complex system. So as you all know, in contrast to mechanical systems in which component parts interact linearly to produce a predictable output, the components of complex systems interact non-linearly over multiple scales and produce unexpected results. And the output of a mechanical system can be controlled by manipulating each of its parts, while the output of a complex system is dynamic, behaving differently according to its initial conditions and feedback. So in our healthcare system, this comprises of networks of components. So these would be things like your hospitals, clinics, nursing homes, rehabilitation units, patients, families. And these components interact non-linearly on different scales. So we've got the patient, we've then got our family medical center or our hospital. And then on a larger scale, we have the government. And often these interactions produce unintended consequences. Things like adverse drug reactions, nosocomial infections, rehospitalizations, etc. So if healthcare is viewed as a complex system rather than a mechanical system, several of its intrinsic properties can be exploited to influence its dynamic behavior and guide it in a more favorable direction. And as health system planners, some of these characteristics are important to take into consideration. So if we consider change, there are 3 main levels of change in the healthcare system. So we have the human body, the organizational context, employees coming and going, and economic cycles or political ideologies. And COVID is a perfect example that we're all hugely familiar with, of something that has invoked change throughout the entire system. So it was a new disease and it affected individuals very differently. Employees and organizational structure of our hospital had to change with virtual appointments, and then at a higher governmental level with implementation of vaccination mandates, etc. We also need to consider trade-offs. So what is the goal and what will the effects be? If our goal is to shorten the length of hospital stay, this may mean that we're discharging patients earlier to other facilities, perhaps nursing facilities, rehab facilities, or enhanced care in the community. So at the hospital level, we have a win. But on the whole level, we have to consider what the whole system looks like and what the impact is. If I move to path dependency, well, the health system is steeped in history. We've always done things this way. In addition, patient history influences healthcare. An example of this, well, if we take, say, a young athlete having a gallbladder removed, they will have very different healthcare resource needs than a patient being treated for asthma, hypertension, and diabetes who's undergoing that same surgery. It's not a case of one size fits all. Nonlinearity, well, key to the success of a complex system is its nonlinear interactions of its components, such that the output is different from the sum of its parts. And a failure to recognize this property, unfortunately, is one of the deficiencies of our healthcare system, where we have established silos of care with less attention to patient transitions and the communication channels between them. And then lastly, emergent and self-organized behavior. So in complex systems, order is emergent through a process of self-organization, and it's maintained without central control. So an example of this in healthcare is prioritization of integrated care. And this care utilizes coordinated and strategic efforts to transform existing health service delivery structures and foster emergent cross-sector collaborations across the system. So our next question was, how do people evaluate complex systems? And more specifically, how do people evaluate healthcare systems? So we looked at a review of 74 studies exploring different complex system methodologies used to evaluate public health interventions. And 45 of these evaluations started with some form of system mapping as a tool to provide a framework for further modeling. One approach we found was collaborative modeling, and this has been defined as the joint creation of a systems representation with the participation of end users, stakeholders, experts, and analysts. And this definition aligned with our goals and objectives of using a co-creation approach, bringing together the wide range of skills and experiences of the Middlesex London Working Group. So where should we start? Well, we know that within our working group, we have a wide range of skills and expertise, but everybody's looking at the healthcare system from different angles. How do we eliminate this experience, expertise, or workplace bias? Well, the importance of developing a clear understanding of the parts of a system and how they interact is illustrated by the well-known ancient parable from India about the blind men and the elephant. And there are many versions of this well-known story. However, the basic premise, for anyone who's not familiar with it, is that each of the blind men feels a different part of the animal, but only that part, to learn what the elephant is. And unsurprisingly, when the men compare their understandings of the elephant, they are all in complete disagreement. There are many morals to this story, but in the context of complex systems, this parable demonstrates what can happen when people have distinctly different perceptions about the same system. So how do we get everybody to see the same elephant? Moving on to Chris is going to tell us about our visual representations.
Thank you, Anna. So we had this challenge. We needed to bring together a working group from across the subsectors of health, with the main challenge of identifying what is the starting point for our health system transformation. What does the health ecosystem look like right now? And the substantial challenge that we had at the beginning was we were, if you will, handed a puzzle box. So we were handed a list of different entities within the health system, but there was no guidance. There wasn't a map available to say this is the complex health system. So to use the analogy, if you will, we had a puzzle box with pieces in it. There was no painting on the outside of the box. And there were 100 pieces. And we had to then start to understand, what are we building? What is the picture that we're going to have at the end of the puzzle? And add color to each of the pieces so that we could understand how they would start to fit together. We wanted to create this visual representation of the health system that was practical, that was relatable, so that each of the individual members of the committee and the broader Ontario Health Team leadership could understand the system from the various perspectives, could see the whole elephant, to use the parable as an example. And we had this image, I think we can go to the next slide, Anna, please. We had this image of a health ecosystem as a multi-dimensional system. So if you will, we were trying to create representations in 2 dimensions, but what we really have is a cube or a polyhedron or some 3-dimensional structure, which is our health system. So what you can see here is a representation that starts from the very highest level, or tier 1, looking at the main components or the main interactions within the health system. And then the next level of care, the next level, tier 2, slightly more granular, looking at the elements of care. This health system needs to provide care to patients. So what is the element of care that we are providing? And then tier 3 and tier 4 would go to the very specific programs that are available, the services that are provided within the health ecosystem. And tier 4, even more granular, looking at the eligibility criteria, whether that's geographic or demographic or what have you. For the purposes of today, we are going to really just look at tier 1 and tier 2. And let me describe for you the creation of the model that we undertook. Next slide, please. So let me orient you to this first tier 1 ecosystem level map. On the left-hand side of your panel, you'll see various layers. So home and community care, underneath that, primary health care, then urgent care, and then secondary health care. If we want to look at home and community care, we could divide out 2 separate elements there, home care and community support services. Under primary health care, you can think about a multitude of components there: laboratories, imaging services, Department of Public Health, pharmacies, social services. Below that, we have hospitals, we have the EMS, ambulance service, we have paramedicine providing care using ambulance personnel in the home. And then finally, on the bottom layer, hospitals and specialty clinics. And what you can see is that each of these components interacts with another component, and this is represented by the arrows. The arrows, some are multi-directional, some are unidirectional. And while this diagram doesn't show it, also each of those various connections or interactions represented by arrows also would have a decision node somewhere along it that would be the rules for the connection. So even at 35,000 feet, this is a complex system with many interactions that we could begin to define and understand. But I would say to you, or suggest, that this diagram in and of itself is maybe impractical or too complex for people to really understand. So we really took it apart at various layers. And so we focused on those 4 boxes on the left, looking at the different points of contact, the different levels of interaction. And we could look at the next slide, which where we start to unpack the system. So if we look at the top, if you are the patient or caregiver, then you have access to certain elements within the health system directly available to you. You can contact home care independently if you're aware that you are able to do that. You can access community support services. You can certainly see your primary care doctor. You can go to an urgent care facility. You can call an ambulance. But if you will, the points of contact as a patient or caregiver to our system are fairly tightly regulated, and many individuals would not be aware of the services that are accessible to them the way our system exists. And next slide, Anna, please. So if we focused on the primary health level, and Ontario health teams are created with this fundamental premise of a medical home, that the primary care practitioner is the center of the system, and that coordination of care to a substantial degree is completed by your primary care provider. And we can see here that the primary care provider has multiple potential points of interaction. In fact, the largest opportunity to help the patient navigate through the system. Next slide. So if we then focus, if we leave for a moment the main components and interactions, the health system is about providing care. So let's start to think about what are the elements of care that need to be delivered to an individual who's suffering from heart failure or from chronic obstructive pulmonary disease. Next, please. So this is another system representation, tier 2, and this focuses on the elements of care. So each of the small boxes is an element of care, and we'll just focus in on that in a moment. But if you will, starting at the top, there's this layer of home and community care, the next layer of primary care, urgent health care, and then hospital sector or various subspecialty care. A similar structure, if you will, to that 35,000 foot level, but now again, more granular. So focusing on the top level for a moment, you can see that we have a patient or a caregiver that may be living independently in their home or maybe living in a long-term care facility. A long-term care facility in the top right, this is also a service delivery. This is a component of care, but also a residence. So it's been captured in that way visually. And to the left, home and community care with various elements of care that are provided, social supports, virtual monitoring, end-of-life care, medication management, etc. And next, please. If we then focused on primary care, you can see primary care has a fundamental element of care, which is an accurate diagnosis, and then medication optimization, immunization. One of the learnings that came from going to this level and looking at the system as it currently existed was our primary care docs would say, yes, we do poverty screening, but it's very difficult. There's a big gap. It's not done routinely. We do mental health screening, but again, it is more ad hoc in the system as opposed to focused around management. And certainly people who have heart failure and COPD frequently have associated comorbidities, including depression and anxiety, and these were thought to be very important elements of care. So in the process, we also identified gaps that we could then move forward with that would inform our future planning. There is extended health, primary care, so not part of what we would consider the usual core, but perhaps should be as we move forward to this new integrated OHT Ontario Health Team model. And then finally, Anna, there is a foundation that we wanted to place around or wrap around the entire system, which was an acknowledgement that there are social determinants of health that are very relevant to the experience of healthcare that an individual has. So across the bottom, you see social determinants of health. This also helps to underscore a principle of complexity, of an open system with permeable boundaries, where there are contextual issues that influence the experience within, that will influence the experience within the Ontario Health Team. And next, Anna. Very good. And I think that brings us back to Anna to review what we've learned about complexity going through the process of creating the ecosystem map, a visual representation.
Thanks, Chris. So what did we learn and how did complexity theory help us? So if we go back to our tier 1, we saw that even from this view, the health system is very complex. And we saw complex systems nested within complex systems, from our human component, our patient and provider, at the healthcare level, and the components within. So our hospital acts as its own complex system. And then our overall system functioning as a whole, so the emergent system, with multiple interactions between these components and agents. And when we looked at the system sliced into levels, we noted that the patient can't navigate the healthcare system independently. In addition, when we considered the touch points and leverage points available, we found that in primary care had the majority of our touch points. And so perhaps an intervention implemented in the primary care level could be farther reaching than, say, an intervention implemented at the secondary care level. And perhaps a demonstration of non-linearity. Interactions are not all equal, and the effect of one interaction may have a larger impact depending on where in the system we implement it. So it's possible, potentially, perhaps an upstream approach could facilitate a positive feedback. So what I was meaning by that is that at the primary healthcare level, if we implement change here, is it possible with our 2 target diseases that we could create a positive feedback loop and reduce our hospitalizations up here? Tier 2, well, here we discovered that care elements are not available equitably across our system. Primary care providers had different resource availability, and this was based on the primary care health team and geographical location. And what we actually saw was that in this level, we saw an example of self-organization whereby primary care providers focused more on the acute care interventions. And this structure enhanced stability because it ensured that our unstable patients were prioritized. So as we move forward, path dependence will be important to consider in the redesign of this system. Consideration of how components operated in the past may differentially influence intervention impact across the system. And as Chris mentioned, we identified it was an open system with permeable boundaries. And this was demonstrated by the influence of the social determinants of health. And perhaps a significant limitation of the current system is that it often incentivizes the treatment of individuals as units of disease and not necessarily as people who exist within a complex ecosystem of unequally distributed resources. So these series of diagrammatic representations used a co-creation approach in their development, which served multiple purposes. But perhaps most importantly, we wanted to reveal the whole elephant. We wanted to create a visual representation that was comprehensible to a broad audience. Unpacking the web of interconnectivity between the different sectors reinforced the perception that an implemented change in one area of the system can resonate throughout. We wanted to create a level playing field that allowed a balanced contribution effort, and we wanted to unify the core working group on a communal path forward. So our conclusions, well, how will complexity theory affect planning of the future state? Well, the healthcare ecosystem map provided a valuable discussion board emphasizing complexity that will need some robust consideration before generating innovative future implementation strategies. So to sum up, if we look at change, well, it could follow, as we've mentioned, implementing a change or investing resources at our primary care level could provide the most system-wide impact. There is a need to consider a system navigation role embedded within primary care. However, there's an interesting caveat to this, and that is that patient navigation can only work if there are places to navigate to, and the concept of nowhere to navigate is most frequently encountered for patients living in rural environments. If we look at trade-offs, well, an example will be our unattached population. And by this, I mean people who have no primary care provider. So we need to take this into consideration. If we implement change at the primary care level, will we miss a patient population? So this needs to be considered in our discussions moving forward. If we look at path dependency, Tier 2 presents a seemingly comprehensive array of care elements, and yet, as previously discussed, they're not uniformly distributed. And in addition, we need to consider the capacity of these services, wait times, access requirements, and regional variability, which poses the question, is it an increase in service availability that is required, or is it the coordination of access to them, or is it a combination of both? When we're considering non-linear interactions, we acknowledge that these demands are non-linear, and therefore it's important that system outcomes are measured in our future state system performance assessment. And by measuring outcomes, we'll be able to assess the emergent system as it self-organizes. And finally, in our future work, it could be valuable to identify leverage points that might foster more proactive, preventive care, as well as consider how current rules governing resource distribution contribute to inequities and inefficiencies. So moving on, we only have one slide here, just our next steps that I think Chris is going to talk about.
Next, then, please, Anna. So having completed the current state map and considering the elements of complexity theory that we have outlined, the next step would be to advance future co-creation activities. Certainly from the point of view of the Ontario Health Team, there was a formal co-creation approach involving patients and caregivers and multiple providers to look to the future principles of the future health system. We have, as part of the work, evaluated or explored health system model and notation as an opportunity for planning into the future. And the next step is the practical step of implementing and identifying 2,000 or 3,000 individuals that would come into the new integrated Ontario Health Team in Middlesex London. Thank you so much for your attention. I'm certain that as we move forward, we will be using the principles of complexity theory in our planning.